Guys, I'm going to fly along a little bit here, and I just want to tell you pretty well from the outset is that I didn't invent anything, and I certainly didn't set out to build a global business. All we ever wanted to do was try and do things better. And if I run out of time and I don't get to tell you that, that's really my message today, is that we don't have to be designers. We've just got to be able to think and look at things and think, is there a better way of doing it? I've been asked to talk about disruption and design and how we can address societal change. And in my particular world, it's going to be all around healthcare. Bear with me, I talk pretty quickly. I'm an interventional radiologist, a nuke physician out at the Hermitage. I spend most of my day putting needles into patients' bodies while they're awake and talking to me, all under local anaesthetic. And it's a fantastic gig. I love my anatomy, I love my pathology, I just love the technology that lets me do this. And it's fantastic. Look, my background is my dad was a country GP. He became the country surgeon. He had 8 kids. He had very little technology. He had the old, he had the tongue depressor, and he had the ophthalmoscope and the oroscope. He had the old tendon reflex tester, and of course the old stethoscope. But he had very little technology, and when people needed him from different country hospitals in the valley, we had to go through what we called a donkey line or a party line, and usually 5 or 6 people were woken up in the middle of the night before we got to actually our house. And it was really a wonderful, wonderful and charming way to grow up. And most important, what Dad was, he was first and foremost a lovely bloke, but he was really, really loved by his patients, and all I ever wanted to do was actually be a doc. And I never thought I'd get into medicine, but managed to scrape in, and I went on and done what I've done. But I've never forgotten the values that he really brought to the people of the valley. I was gifted, or blessed, I suppose, I meant to say, to work in Sydney and Perth and London at the Royal Postgraduate Medical School, Kev, at the old Hammersmith, and you've told me to say that was the 5th biggest employer in the world, as it was, and then rescued up to Cambridge and over to Stanford, and then back into Australia. And I'm going to walk you through a little bit of that. But it was at the Hammersmith, the day that I arrived, and this was almost 20 years ago, they turned on the very, very first ever totally filmless and paperless radiology department. They did away with the old red glasses in the radiology room, and they did away with the chemicals in the dark room, and they did away with the old transparency going on the old viewing box and the magnifying glass and the wax pencil and the old protractor and old dictaphones. Did away with all of that and went digital. It cost £28 million. It was sold to the NHS as being cost neutral. It was heavily, heavily cost positive in terms of people and time. But what it did show me was that if ever, ever, ever we could get hold of that technology, boy, what an impact it would have in parts of the world where I grew up. I went off to Stanford and then came back, and an Irish radiologist invited me to go up and do a locum high up in the bush. And my brief was I had to do ultrasounds on 48 mums, 48 women. I've given it all away now, in 48 degrees, and it was 200 kilometres directly east of Fitzroy Crossing, a dry area. And I went with Albie in the back of an old Toyota truck, and my job was to do ultrasounds on the mums. Now, these are my first 5 patients. They're all female. They're all related. My little daughter will say they all went to the same hairdresser, but they're all pregnant and they're all diabetics. And the problems with diabetic mums is that they hang on to the sugar. When the sugar goes across the placenta, the little bub sucks up the sugar and grows. Not a diabetic themselves, can be later on, but they become quite big, and we call that macrosomic, large-bodied babies. And so when that bub goes to get delivered, we end up losing both mum and bub during that stage of delivery. And it's still to this day one of the biggest causes of death of Aboriginal women of childbearing age is this problem. And so it was this particular day that I was doing the ultrasounds out of the back of the truck. And for those who've been blessed enough to see a normal ultrasound, that's what it looks like. And this is not. This is I did a 4-molar pregnancy, a terrible, terrible complexity of pregnancy where all of the gestational layers become heavily intertwined, and unfortunately it has the ability to shower off little vascular pieces of tissue around the body, and mum can actually perish from that. And so the treatment in those days was to do a hysterectomy. Now we'll have different techniques and we can still preserve the life-bearing capability of mum, but in those days we couldn't. This was the 11th of 1995, Remembrance Day. And I just felt that night there had to be a better way. The only solution we had was, if in doubt, fly it out. And about 12 to 15% of all of Royal Flying Doctor Service retrievals are for obstetric crisis. And it was then, as I said, that I just felt that there was this divergence between these centres of excellence where I'd been blessed to work and the actual level of care that these patients were getting out in this beautiful, stunning part of the world with this gorgeous blue sky and this unbelievably red dirt, but virtually nothing when it came to basic healthcare. And so I suppose there was this compelling need to redesign. I didn't set out to redesign anything. I just thought there has to be a better way of actually doing it. The real problem was that the old waiting room, she was pretty big. She's some 2.5 million square kilometres, the Western Australian paddock. She's 4 times bigger than Texas, just for the Americans in the room, just to put them back in their box. But she's made up of these small, isolated communities which are distributed over this huge geographical area. And really, there wasn't any connectivity at all, and we couldn't really deliver a point-of-care service. But I remember what we did at the Hammersmith, and I thought, what if I could get that technology? I put ads into all of the Australian papers, and I got 3 young lads from Wollongong to come over, and I showed them. I took a videotape of myself reporting 50 films on the old way, and I said, everything you see me do, can you do it faster and better and safer and cheaper maybe, and do it in a digital way? And they said, oh yeah, for sure. So 10 days later, we actually did, and we built a telemedicine network, and it worked. We started with a little ultrasound machine. This was the day I took the photo. Unfortunately, I left the laptop on the top of the roof going down the hill, and off she came, and they were my first 4 patients. And I thought, at that stage, Kevin, if you were doing a television show, you'd step in and say, stop now. But we didn't. We punched on, and we built something really, really special. And all the way along, we tried to match the clinical requirement to the needs of the communities that we serviced in Harvey, in Collie Donnybrook, Bridgetown, Manjimup, and Margaret River, all in this really, really beautiful part of the world. And it was really quite exciting. And from Fitzroy, bit by bit by bit by bit by bit, we built this whole thing. And we did it all on a 3K copper telephone line, which was horrific during the wet season up there where we lost so much signal. Never heard of the World Wide Web or the internet, which eventually came along. And when it did come along, it allowed me to do things that we just couldn't have even dreamed of what we could do before. Suddenly we were able to link through to my old bosses in the Hammersmith and Cambridge and Stanford for second opinions and for squamous cell carcinoma in the lateral wall of nose. I was able to get the best opinion from anywhere in the world, literally, quite literally, within an hour, not yet at that stage in minutes. And we built what became a global network called Global Diagnostics. And I suppose we had 400, punching towards 450 on the team at that stage. We're moving now towards 500,000 patients a year. And it gets to a stage where I think the founding person, whatever you want to call them, the entrepreneur, I wasn't, I was just the doc, but it gets to the point where it's now a scale issue. This is no longer that real juicy part of startup and getting stuff done and making things happen. And so I stepped out of global and help facilitate an MBO management buyout there where the boys are all, and the girls are all kicking on and doing some great stuff. But for me, what next? Look, I love doing the fun stuff, and I apologise for not being there last night, guys, but I stick needles in and I get to talk to the patients. I get them to put on a glove and help me, and it's just a really, really wonderful, wonderful life I live. But I do think that there's just one more disruption left within me. And when you look at, well, what would you disrupt, Johnny? I'd disrupt the chaos of the way we deliver healthcare today. We spend so much of our people, time and dollars in that acute care box, and I think we really need to step back and think there's got to be a better way of actually doing this and fixing it. And you might say, well, Johnny, what's the problem with that? Well, the problem, I reckon, is that it's a doctor-focused model, and that's unsustainable, it's unscalable. I think it's unsafe. We know it's highly, highly inefficient, and there are better and faster and cheaper and more safer ways of actually delivering the care that we all embark to do. So the solution, I think, is stop patients coming into the acute care setting by keeping them well within the community. And in fairness, there's been a lot around empowering the general practitioner, that really, really mighty warrior, the community nurse, the pharmacist, this unbelievable intellect, which we just don't even tap into. And then be able to work with the dentists and the physios, all within the community. But what we really need to do is go out and talk and listen to our people and see what their problems are, engage them, embrace it in a way that they've never been embraced before. And I think we can deliver this all within the sanctity of their home. How? Just by using simple, mobile, connected, and very, very personalised now technologies that we've all got in our pocket. Can it be done? I think it can. I think we're at the moment working towards partnership on building a cloud-based, personalised, secure, 24/7 electronic health record, which basically is in the morphological shape of a tree that gives everybody in that family a branch on the tree. And now with sensors, we're able to acquire biometrics that we've never been able to do before. And through low-energy Bluetooth, we can push them through to a tablet, controlled, I think, by the real warrior of the family, which is the female. 92% of all my patients that accompany the patients that I operate on are female, and they're really, really the custodians of care. So how can we embrace them so that we have a full chronological history of everything we need anywhere in the world? So at 2 o'clock in the morning, we don't have to get the kids out of the bed. but we can actually do a virtual consultation. Just this week, you're hearing all of the insurance companies coming out and beginning to offer this. It's there, it's doable, it's simple, it's safe, let's embrace it. And put the true warrior at the front and in the centre of her ecosystem, all the way from conception through life's milestones, through to that really, really important end of life, with that dignified dying. And I've just gone through that with my lovely brother Phil, and there's so much that we have to do in that space that we haven't even scratched yet, and still being able to link in through to the various members of her ecosystem when and as she needs it. You might ask Johnny, like, is this really the future, or is this just a fad that's going to die? We know that there's going to be 50 billion connected devices tracking healthcare within 2020. And we need to pour petrol on that. And now along comes this thing, the Internet of Things. And where do we all fit into that? And you've got to ask yourselves, every single one of you, from whatever domain you might be from here today, ask yourself, what impact is this going to have on the way you deliver business? And how can you use this to facilitate a better way of delivering care? Because I don't think we're going to be making that decision. I think it's going to be the consumers who are going to lead this tsunami of disruption. And I just want to step back and pour petrol on them and just fuel them up. The Internet of Things means that anybody, on any device, anywhere at any time in the world, on a myriad of networks, can now go into any service business, health included, and basically become a major, major driver of how they want to basically participate with that industry. The potential annual global economic impact for healthcare alone by 2025, that's 10 years away, 2.23 trillion. Now, where would we go in and try and start using this sort of technology? From the conception all the way through life's milestones. If you think of where we're spending all of our money, it's in the chronics, it's in the aged. So how can we actually embrace them and create something very, very special? It's a multidimensional challenge, the ageing process. We've got 27% of Irish people 65 and over living on their own. But don't think they're not connected. 70% of them have mobile phones, 10% of them are smartphones. They've got their laptops and their tablets. They're spending, 24% of them are actually engaging on social media, albeit at a little sort of superficial level, and spending 2 to 3 hours a week in this sort of environment. So don't think for an instant that the aged aren't going to be able to be a part of this disruption if and when it comes about. They're already linking through to their doctors, they're organising their appointments, their medications, the disaster of the paper electronic health record. They're using Halo and Health for Halo type processes to be able to get them to and from hospital, and they're building communities within their own communities, whether it's Alzheimer's or Crohn's disease or whatever else it might be. They're out there, okay? And it's not just one directional. We can actually have a bi-directional interaction here now. So we can help monitor for falls and smart beds and nappies to see whether or not they're taking enough fluid in, if they're appropriately hydrated, all while they're in the sanctity of their own home. There are so many apps out there now trying to stimulate and create agility within the mind of our age. We need to be able to step back and pour petrol on that. And all of this, bringing it together. You might ask, well, what are the benefits? The benefits are that we have an almost younger, more agile, physically and health-wise aged population who'll be able to step up and start taking some responsibility in a really, really different way for some of the chronic diseases that we're actually going to all be cursed with unless we get in there and try and prevent it early. Okay? So then what's the byproduct that everybody's so frightened of? Look, it's data. And it's not going to go away. It drips off the walls and it comes at me left, right and centre on every single patient, every minute of the day. And same for you in your own domains. With the predictive software now, we've got the Apple Watch coming out hopefully later this week with the Jawbone and the Garmin and the Shine and various other things. We're able to get predictive analytics coming now, which will have an impact on the smart ager in a way we've never thought of before. We're going to be able to link through to the primary care, the acute care team, be planning the discharge before the patient even gets there. And when they get into hospital, get them in and out as soon as possible, married against best practice algorithms so that we can get them back into the community and keep them out of hospital and do away with the expense that goes with that. That's a big old win for the public health planners, the regulators and the insurers. The problem is there's a bucket load of data and it's coming at us in a massive, massive wave. Sources of data in healthcare, there's just a myriad of it and it drips off the walls, as I said. Biggest problem of all is that paper record. It's a disaster and we need to step up and do something about it. But all of these other, the gene sequencing, 23andMe, back on the map at last week, home monitoring, a whole new world of disruption, and social media. We think we can save $3 billion by appropriate use of big data over the next few years, just through administration and better planning. The real challenge we have is, what does it all mean? You know, there's a bucket load of data, but where's the real value that's coming out of this? And what's it going to cost us in terms of people, time and dollars? But if we get this right, we can create a personalised way of delivering healthcare that we've never been able to deliver before. We're able to go into preventative medicine and stop disease before it actually happens. And if we get this right, if we get it right, we've ended up simplifying the way we deliver health and do away with the chaos. We've engaged and embraced the warrior in her own home for everyone she loves 24/7 and frees up the resources so that we can spend the time on people who need to be in hospital. We need to go in, we need to look, listen, design, really disrupt in a sensible way and transform the way we deliver healthcare to the people on our planet. And that's all I really wanted to say.